And now make you host. Make host. Yes. And now you have all the controls in the world.
Beautiful, thank you.
No worries. I'm going to run. Good luck.
I'm so much more technologically aware now. The things that we've had to learn.
Fantastic. All right. I'll catch you later.
All right. See you later.
Bye.
Hello, Ruth.
Hi, Helen.
Hello. How are you?
Yeah, good, good. I've just finished watching the sexual thing. Yeah,
Yep.
yes, that was very good. Yeah,
I'm hoping we'll get a nice group tonight, but
Yeah.
if not, I have got another PowerPoint.
okay. All right. Was someone are you presenting?
I will, but if we get a lot of people who want to ask questions and interact, that would be great instead.
Okay.
But otherwise, I'll do my presentation.
Yeah. Yeah.
It's funny because a lot of people see that there's the meetings, the Zoom ones, but they just never come to them. But there is a lot of views of the recorded ones, so I think they're probably all over 100 views now, which is good.
That is good attendance. Yeah. Yeah. Oh, you've done great job with it.
Yes.
Have you found it stressful or difficult?
The IT stuff in particular has been.
Yeah.
I'm not good with that stuff, and we have had some IT assistance.
Yeah.
But we probably needed more. And just so you know, we're recording at the moment because Paris set that up for us.
Okay.
So there'll be a bit of waffling at the beginning for anyone who watches later.
Oh, yeah. Oops. Let me turn it off. Okay.
Only a week to go until SENA How
Yeah,
exciting.
I know. It'll go well. I know.
Yeah, yeah.
Be fine. It's not like it's high tech stuff and high
No,
profile speakers. It is what you make it, really.
exactly. Yep.
Yeah, yeah,
And it's always been that nice little community feel to it with people.
yeah,
So it's good
yeah,
to keep that.
yeah, yeah. Are you in the new facility?
Yeah,
Oh, yeah. And it's
yeah.
all the transition's gone well.
Yeah, we've been here just over 12 months now, so
Okay.
yeah,
Oh, that's
almost used to it.
would be.
Mind you,
Yeah.
we had some works that needed to be done that 12 months down the track they still weren't done. Little things,
Oh,
so
okay.
we're getting there with it now.
Yeah. Yeah. Well, they've done a massive. There's been this massive building, Prince of Wales,
Yeah.
$100 billion thing, and they're slowly transitioning the wards over, and even the casualty
Okay.
going over. But my friend who works in one of the wards said the very first day they had a meltdown with a patient, and she did $10,000 worth of damage. She smashed things, and
Jeez.
so
Oh,
it was a real baptism of fire.
yep.
And yeah, it was a hot mess. But they'd go
Well,
down.
I set off my office duress alarm just after we moved in. We'd had a power outage the night before, and I came in, and we've got those desks that go up and down, and it wouldn't work. And I figured, oh, it must just be that it's turned off. So I pressed a button and nothing happened.
Mm.
And there was another one I thought, oh, maybe you got to press two, because I remember years ago some child got squashed under a massage table. And I
Yeah.
thought, well, maybe this is similar and you don't want someone getting hurt, so there's two buttons. So I pressed both. And this high-pitched scream went off. It was supposed to be silent, and it wasn't,
Oh,
because you don't want to set someone off even more.
yeah.
And then it took them, I think it was about 20 minutes to get here. So I would have been dead had it been real. Everyone else came, of course. I was dying from embarrassment.
So
And then
security come, obviously.
security came. They went to the other ward instead of here, because probably they just expected it to be there.
Yeah.
And then they
Yeah.
came over here, and they didn't have some key they needed to switch it off, so they had to go off and come back. And yeah, that's happened a few times.
I was
So
good
I
practice.
now know, don't press the red buttons under a table that goes up and down.
No, I remember that. Yeah. Is anyone coming over from Adelaide, Dina?
I don't think so. None of my staff are all really new, so 80% of them. Some are 12 months, some are 6 months, and some are still only just starting now. So I think next year is when we get a lot more
Yeah.
people really getting into it. And yeah, airfares are a little bit up at the moment too. So
Yeah.
yeah.
Is Paris, what's his role? I've met him.
Paris is a senior, oh, and he'll hear me say this, or a senior education-y person at Hollister. So he's one of the senior people there.
Yeah.
Does global education
Mm.
things and helps with all this kind of stuff too, which is nice.
Yeah. Yeah.
They're all really nice at Hollister.
So good.
And of course, we've got the big ANZCOS conference in Adelaide at the end of the year,
Yeah.
which
Yeah.
should be good.
That's great. Yeah. You're not doing anything with that?
I'm organising it, but
Oh, are you?
yeah,
Wow.
well, I'm not. Apparently, I'm the chairperson or whatever, the convener.
Oh, wow, that's huge.
Yeah. We've got a proper management group. So, one of these event organisers. So they do all the hard work for us.
Yeah.
Yeah, but that should be good.
Wow. Are you emceeing some of it?
Not if I can help it. I'll stay in the background.
Yeah.
Yeah, we usually will divide up chairing of sessions between everyone, but again, I'll try and stay in the background for that.
Yeah. Well, I did get my people to print out all of the NSCOS stuff.
Oh, that's nice.
Yeah,
Good,
so
thank you.
but I did read there that there's 200 delegates that they're expecting. Maybe
Yeah, we
more.
usually get somewhere around 150 upwards, and because there hasn't been a face-to-face one for a while,
Okay.
so fingers crossed.
Yeah, yeah. Mm.
Might just be us tonight. It's only just
Just on.
time. Yeah.
So what kind of speakers or what kind of conference? Is it always scientific? And I've been to 2, but
No, it's a real mix. So we're still getting confirmation from the speakers we've invited. If you go onto the ANZCOS website,
yeah,
where the conference is, they've put the bios on there already for some of the speakers. So a good range of people.
yeah,
I think there's someone who has a spinal cord injury himself and is a doctor. Someone else is a researcher. So they've got that lived experience as well.
mm.
So yeah, a nice range, and then we'll be opening up abstracts soon as well. So
Okay. Yeah.
yeah,
Oh yeah.
we've only got one sponsor so far, so that worries me.
Wow.
We're going to need a lot more than one.
Yeah. Yeah.
We only sent that out last week though, so I just have
Well,
to.
it's only what's in November, isn't it? So
Yeah.
yeah.
Usually you'd have like probably about a 2-year lead up to it, but it was supposed to be held in another state, and then they're all new, so they couldn't do it this year. So it was only towards the end of last year that we said, yeah, we'll do it.
Mm.
And then we picked our venue, and just after we signed the contract, they decided that the following day or the Friday or something, there's some big car race that they've re-signed to happen at the same time. So it's, oh my God.
Oh no.
So we've been trying to snaffle up some accessible accommodation nearby before people take it all. So we should be right with that.
Yeah, that's a good idea. Do that.
There's Randy.
I'll just remind Annette.
Hello. Not many of us again.
No.
It's still early. We'll give him a few more minutes. Paris logged us on, and then he's gone off to see a man about a horse or dog or something.
Okay.
But we are recording now, so that
That's
we're
good.
all ready to go.
Well, it's nice that you have joined us, Ruth.
Thank you,
Yes.
Randy. Yeah. It was only 1 hour ago that I listened to the sexuality Zoom.
Ah,
So I caught up today with a few things. Yeah. Where are you calling from?
I am from Denmark. It's a Nordic country in Europe. Yeah, small country in Europe.
Yeah. I think I read yesterday it's one of the happiest countries of the world.
It is. I think Finland is happier than we are, but
Okay. Well, I'm from New Zealand, and I think New Zealand will come 10th, so it's not bad. Yeah.
Well, I guess we have also related to healthcare system. We have a very functional system that helps if we get, for example, if we get ill and things like that.
Yeah.
So
Yeah.
that security, I think that's important.
You've got a female leader too, haven't you? Prime Minister.
Excuse me?
Have you got a female Prime Minister?
Yes, we do. Yeah.
Ruth, our committee, our nurse interest group committee at ISCOS. So we've got Randy from Denmark, me from here. We've got Tracy, whose last name I can never remember, from Queensland. And then we've got the UK. We've got, where's Letitia? She's in
Sydney.
America.
This is in America. Yeah.
Mm,
and Veronica,
Germany.
Germany.
gosh,
That
yeah,
it?
it's
We've
pretty
had a
good.
few others that have kind of dropped off as we've gone along, but
Mm,
we're definitely worldwide.
yeah, it's good.
And we had 60 countries join the MOOC too, which was really good.
Yeah, that's a lot.
Yeah.
And how's everything with you, Ruth? You've had some extreme weather conditions.
I'm actually in Sydney.
Okay.
Yeah, yeah. I mean, I'm New Zealand born, and my family are all New Zealand. But yeah, so I've been here 30 odd years. But yeah, there's a few things that have rocked New Zealand the last few years, but they cope. They're very resilient people.
Mm.
Yeah. Well, Australia, we're a country of extremes, so we've some floods. And yeah, it's interesting.
We're still getting those little bursts of hot weather too. It was 32 yesterday, I think.
Yeah,
Not sure about today. I've been stuck inside all day.
yeah. I'm just going to remind Annette, I'll send her an
Yep.
email.
I hope there's nothing wrong with the link. Well, Ruth's here, so there can't be.
Yeah, no.
And I'm sure we had the time right this time.
Yep.
We're having a power outage at work for 5 hours on Saturday while they fix a transformer. We had power go off and it didn't go to the backup generator because there's something wrong, so they're fixing it. Just all the little things we have to think of, because all our doors are swipe card now, everything. So everything will be open, including the medication room and the DDA cupboard. So we're going to have a guard sitting there. So I've spent hours today just thinking, oh, we've got to get everybody off air mattresses and put foam ones back on so they don't bottom out. The fire doors in the ward will close. People can't get through. No hot water. No cups of tea or coffee.
Why is there no emergency power or emergency
The thing that
generators,
makes it
like that?
switch over doesn't work. So they've got to replace that whole thing.
Okay.
And then hopefully it will work. At least it's not the middle of summer, because that would have been unbearable. So
Should we just start?
she's just checking Annette. So I don't know if you want me to just go through a PowerPoint for just the three of us.
I think it's a good idea because people view
They will watch
recordings
it
afterwards.
afterwards.
Yeah.
Is Annette coming on, Ruth?
Yeah, I've just reminded her and sent her the link.
Okay.
Okay.
Well, I will start, I think, if I can get my PowerPoint up, and I'll just click share screen, I think, and then put it up. Well, that's it there. And slideshow. It's there. I don't know how to make us disappear though.
But we're just in we're not in front of the PowerPoint, not from where I'm looking. So it's good for me.
Okay. All right. So. All right. So I'm just going to talk about pressure injuries, how we assess. Have you, Randy, can you see if anybody's waiting to get in? Do you have access to that?
It doesn't look like it.
Because I can't see that now.
No, but I will keep a watch on that. I will look
I
for
just heard something ding. I thought there might have been somebody waiting. Can't see it on here. I'll just escape from this just very quickly. No. All right. Well, hopefully you'll see if anyone's waiting and be able to let
I'll
them
look
in.
for it. Yeah.
Okay. So we're looking at assessment, prevention, management, and then I'm going to talk about Chester. So Chester was a real patient. That's not his name. So these aren't his real details. There's some changes. So skin, we know that that's the largest organ in the body, and the three main functions of it are to protect us against dirt, foreign bodies, infections from the sun, be very sizzled up hearts and lungs if we didn't have our skin. It's for temperature regulation through our sweat glands, restricting and increasing the blood supply to skin to help with maintaining an even temperature. And skin's also there for sensation, and that can be for touch, for pain, for pleasure. So what is a pressure injury? And pressure injuries, of course, are also known as bed sores, decubitus ulcers. So the Pan-Pacific guideline defines a pressure injury as a localized injury to the skin and or the underlying tissue, usually over a bony prominence, and it's as a result of pressure, shear, and or friction, or a combination of them. And it can be caused by shearing, where you have the mechanical force. So the outer layers of the skin might remain still, but the deep fascia moves. And we see that when somebody's sitting up in a bed and they slide down, and you'll see like a bit of wrinkling up of the skin, but their bottom has slid down, so you get that real shearing force. Friction, when you've got two surfaces moving, and that happens a lot. Of people drag themselves up the bed, or they pull themselves across the bed. And just the pressure, and that can be something internal, so it can be if someone's got a fractured bone and that's pressing against the skin, or something external pressing against the skin. And moisture will also alter how resilient the skin is. So how does it develop? Well, with prolonged pressure or friction or shearing, we get restricted blood supply to the area. The cells will be deprived of oxygen and nutrients, and that's when damage occurs and you have a pressure injury. Once they've had a pressure injury, the skin and tissues will never be as strong again. They'll always be weaker, less elastic after the pressure injury is healed. And that's why we often see people with those multiple pressure injuries. They heal and then they get another one. So they're all the high-risk areas that I'm sure we know. Some of those are from, you've got equipment, nasal cannulas, things like that that could be causing them. But for some people, even just having a sheet or a blanket over their toes is enough to cause a pressure injury. And when someone's laying on their side, again. So when we have, for us, for every admission, we do a pressure injury risk assessment. And doing a risk assessment is a way to determine who's at risk of developing pressure injuries and how big a risk that is. That assessment is also used in conjunction with a clinical judgment. So you may do your Braden scale and it may say they're very high risk, but you can look at that patient and know that they're not as high risk, and you don't need to implement everything that Braden score is telling you. An example of that is with some of our patients who come in, we do a Braden score, they're a high risk, and it might recommend things like air mattresses. We know if they're on an air mattress, they can't reposition themselves, they can't transfer in and out of bed. So we do have to be careful that we also use sound clinical judgment. It does provide a basis for implementing things to assist with preventing pressure injuries. And it includes a validated tool. We use Braden. There's a lot of other tools out there. A skin inspection, and we do that usually twice daily. So for us, it's when we're helping somebody in the morning, when we're helping them to bed at night, and then teaching them to do that for themselves as well. And we look at patient history and assessment of them as well. So finding out have they had pressure injuries before, what's been going on for them. So with all patients, we need the history, the visual skin inspection. We need to be assessing their mobility, how active they are, their nutrition and hydration levels. We have some dietetic services. We don't have our very own, so it's a bit of a wait for some people. We need to include their continence management, look at their cognition. Are they understanding what they need to do to help prevent getting pressure injuries? Assessing their pain management, and again doing the Braden assessment. So risk factors are age, of course. As somebody gets older, the skin becomes less elastic and is more prone to problems. If someone's got arterial disease, low blood pressure, anemia, smoking, because we know that that really impacts on wound healing, but it also increases the risk of getting a pressure injury. Again, looking at their nutrition and hydration. So when we have assessed somebody's risk level, we need to make sure we implement a pressure injury prevention care plan or a plan of care. It needs to be individualised for that particular person. Involve the patient, family carer when possible in developing that plan. They're more likely to, I don't really like the word compliant, but they're more likely to agree to do things and implement them if they've been involved in making the plan. Refer to allied health where need be. All of our patients see OT and physio. Psychology is available to all of them, but in other areas or in the community, you might need to make particular referrals to these different areas. We need to look at someone's seating, how they're transferring, review their bedding and their cushion, and that's more so for people who have been readmitted with pressure injuries rather than someone who's brand new to the ward and hasn't already got those things in place. Pressure mapping is really good, so we do have a nice new pressure mapping piece of equipment that I haven't actually seen in use yet. It's owned by OT or physio, but it does show, particularly for someone who, if they're up in a chair and you want them to do some tilting of the chair because it will relieve pressure, when you can show them that on mapping and they see the red fades to blue, they really understand it a little bit more if they're visual. So using things like tilt-in space wheelchairs and just being careful of things like any orthotics or splints, if they've got neck collars on, any other kinds of tubing and stockings. We had a lot of problems with TED stockings where people were coming in and it was almost like their toes were ring-barred because, the hole at the end of the stocking, instead of being pulled down over the end of the feet, was around the toes. And of course, with a spinal cord injury, sitting up and you get all that swelling in your legs, they were getting awful pressure injuries. So to prevent them, we need to make sure we're managing their continence as best we can. We avoid pads as much as we possibly can because it doesn't matter how good the pad is. If someone's sitting on it all day, they're going to be wet just from the pressure of sitting on it. And if they're not great pads and they've got a lot of plastic around them, it just increases the risk so much. Making sure people attend to their hygiene and looking after their skin. We use Linavera oil, which is a really nice one. If someone's got a stage 1, it's got all these super things in it that help, and it smells really nice. And we found I think they're Mernlicher products, the Epiderm ointment is really good for that really dry, that papery old people kind of skin. It's beautiful for rehydrating that. And then you've got the Epiderm lotion as well, which is more of a nice softening cream that goes on. Using things like the Mepilex Heal, which really helps with friction more than pressure in the bed, and using that on sacrums as well. So just whatever products are around that can be used, but avoiding anything like a donut. Or we did try and get up a little bit of a thing going on Facebook with what are some of the older types of pressure injury things that we use. So the glove that's filled with water and tied around a heel. So a lot of those kind of things. I think in some places they may still be used. making sure there's a good repositioning regime and doing pressure lifts or pressure movements when somebody's up in their chair. So whether they're independent or assisted with those, and getting them in the habit of doing those regularly. So I think it's every, I can't remember now, every 15 minutes for 30 seconds. There is a set schedule, and it's just gone out of my head now. But I'm a bit mean sometimes. I'll be maybe in a meeting with a family and the patient, and we're talking about things like skin, and I'll say, you know, you tell us you know how to do that, but you've sat there and haven't moved for almost an hour. Just to remind them that you've got to think about it all the time. It's not something natural. We move when we start to feel uncomfortable, but for majority of our patients with a spinal cord injury, they don't know that they're uncomfortable. They don't know that they're getting a pressure injury until it's already there. Making sure that people are actually eating well, not just leaving a meal there and expecting them to feed themselves. So helping where we need to, doing the skin checks, of course, and in discharge summaries, making sure we document their risk and what we've got in place to help to prevent anything. And every time we assess and implement something, we then need to review it and see if it's working or not. So with repositioning, it should be based on an individual patient assessment. We had some documents written for pressure injury prevention, and it was every patient must be turned every 2 hours. And we know that's not realistic. When someone goes home and isn't going to be getting turned overnight, we have to get them to where they're at that level in hospital. So that involved us rewriting a little bit of the policies, making sure that correct equipment's used, so using slide sheets to move people around in the bed, not dragging them, using lifting machines. If someone's not sitting right in the chair, don't try dragging them back, actually get the lifter out and reposition properly. And the little tip, if someone's sitting up in bed, move them up the bed and raise the knees on the bed before you sit them up, and that will help stop them slipping down and stop that shearing. And if they're on an air mattress, there are some you need to adjust the pressure, but a lot of them now you don't need to. They'll automatically adjust if someone's sitting up in the bed. And again, tilting the bed just a tiny bit with raising the foot end to help stop that slipping down. Keeping heels off of the bed surface, and there's a test just with a piece of paper. You should be able to move that freely under someone's heels. Seating in the chair, and this is where our OTs are so good with making sure the chair is set up to really suit someone so that they're sitting right. And when people are up and moving around, just checking that they're not getting any friction or pressure from their clothing, from their footwear. We had a young fellow once who was getting pressure injuries around his scapula, and we found it was when he was trialing some manual chairs and just that pushing. He was quite a thin, bony young fella, so we actually put the Mepilex heels on his shoulder blades, and it stopped that friction. They're just some of this is how you should put someone's feet, with a nice gap underneath. That's not how you should put them. And then if you're going to put a pillow between, making sure they're nice aligned. Making sure straps aren't too tight, that arms aren't left dangling off of armrests, feet are on foot plates and stockings aren't all curled up. And making sure we're giving our patients lots of information. So I don't think we actually use that one anymore, but it's whatever information you've got and making sure it's documented. I know that that's where we fall down. We do things, but we don't document it. And just discussing everything and involving the family and the patient as much as we can. And different types of equipment. So with mattresses, you've got the constant low pressure. So something like a Roho, we don't use those on beds anymore. You've got the alternating ones, and there's an increasing range of those coming out on the market as well. And the price varies from the Nimbus, which is still really expensive, down to some of the newer ones that are about a third to a fifth of the price. So you can get 3, 4, 5 for the same price as one, and they are really just as good. And making sure that you consider what somebody needs at home before they're discharged, so they have the right equipment in place. Just that little term there, bottoming out, that not a lot of, well, not everybody understands. So it's just what happens when there's not enough cushioning to stop the pressure. So there's just a little diagram there of putting your hand under the support surface or under the bony area and making sure that there's at least 5 centimetres support underneath. And make sure people have the right equipment to sit on. So when we're looking after someone's skin, we don't want to be vigorously rubbing or massaging the skin, particularly over those bony prominences. We want to gently apply things. Don't ask patients to pull themselves up the bed. And for our guys, it's not good for their shoulders as well as not being good for their skin. And if equipment is damaged or incorrect, don't use it. Reassess their skin as we need to, use the right equipment. And as I've said, involving the patient and their family is so important. Gently apply any topical creams and frequently checking under any orthotics, medical devices and stockings. I've got all the stages here. I'm just going to click through these really quickly. So there you've got lovely intact skin. Here you've got the stage 1 where it's just red and not blanching. Stage 2 where you've got a little shallow wound or a blister. Stage 3, you're getting down to the full thickness tissue loss. You might be able to see some subcutaneous fat, but you can't see any bone, tendon or muscle in that one. Stage 4, you may be able to see some bone, tendon, well, you can see bone, tendon or muscle underneath. There might be slough or eschar on some areas, but you can still see to the bottom of the wound what's there. Then you get the unstageable pressure injury with depth unknown, and they're usually like that, the blackened heel. And the ones where, again, suspected deep tissue, depth unknown, and they often, sometimes a blood blister will look like that as they slowly start to reabsorb. So they don't have that hard eschar layer necessarily, but it's dark and you can't see the base of the wound. So when we're managing them, we just have to make sure that we're documenting in whatever form of documentation we use and to describe them really well. And if you've got a document and people who don't really know how to describe the wound or what all of those different things mean, then they need some education rather than just copying what the person the day before wrote, because we still see that a lot. It'll look like someone's got a nice clean wound and you look at it and it's just covered in slough because they haven't known what those different terms mean. We have something here called safety learning system. So if someone has a pressure injury, we report that. And again, putting in a pressure injury management plan. So we put one in to prevent pressure injuries. And if somebody gets a pressure injury, we then need to put in a plan for how to manage that. So wound management, it's based on assessing the wound and what you need to do to help the wound heal. So,
sorry. I'm on.
I just muted her. So you're looking to see if there's any kind of infection, how much exudate there may be, what the surrounding skin's like, is there an odour? And that will help guide your choice of dressing. And it's also important to consider the cost because we don't have great funding for people for wound care. Most people have to pay for their own. How easy it is to use, does it help with pain? What does it look like? Is it something that is going to kind of cover up what's going on underneath, or you're going to have some nasty pussy stuff visible to everybody? And if it's available, you don't want to start somebody on something in the community that they can't actually get. And it's important to check. There's some pressure relieving dressings out there, but you've got to be really careful and check the surrounding skin that that's not getting excess pressure. So Smith and Nephew have the time principles to help with deciding how to manage a wound, and these can be found on their website quite easily. So T is looking at the tissue, whether it's viable or not. Does it need to be debrided and how? And what to put on the base. So often that's a gel or a paste. Versajet, we had that a while ago. It's kind of like it's like an air jet kind of thing for removing slough. I haven't seen that for quite a while though. I is for infection or inflammation, and you may be choosing one of the dressings with silver in it for that, or iodosorb, something that will help reduce that bacteria. And of course now we've got things like I've forgotten the name, granudacin and macrodacin, so prontosan, the things that will cleanse the wound as well and help relieve some of that bacteria. You need to check the moisture balance, so you don't want anything that's too wet, but you don't want anything that's too dry. And E is looking at the margin of the wound, so is it starting to come in and heal nicely? Is it coming in too quickly and leaving a big pocket underneath? And things like negative pressure wound therapy as well to help with healing wounds. Complications of pressure injuries. So they can be prolonged time in hospital, which has a great effect on people's lifestyle, on their jobs, on their family, if they're in hospital for weeks, months at a time. A great big psychological effect, of course. And we sometimes find people don't want to have a look at their wound, or they'll look at it once and they never want to see it again because it can be quite confronting. Some people really need to look at it so that they are confronted and they do realise how bad this is. There may need to be surgery. There's a huge cost associated with caring for pressure injuries, more so in hospital, but also in the community, a great cost, so particularly if they need extra care put in place to help look after them. We said before, once there's been a pressure injury, that tissue is never the same, so increased risk of further breakdown. They can get infection and illness through those wounds, and of course, there's a mortality rate attached to it. So this is Chester's story, and there are a couple of slides in here of some wounds. So if they pop up and you don't want to look at them, just close your eyes because I can't remember where they'll pop up. So Chester was a 62-year-old man who had a motor vehicle accident in 1978. He was a T4 Asia A. He had had no problems with his skin for 39 years, and that all changed in 2017. He was a very independent man, very self-sufficient, extremely resilient, and had fantastic coping skills. So in July 2017, he went to hospital for a CABG, and that's a cardiac procedure of some description. I can't remember the details now. He developed pressure injuries on both of his hips and under his scrotum. He wasn't turned while he was in ICU following that procedure, and he didn't know that he had these pressure injuries for about 2 weeks. And that's when some turns started, because he couldn't feel them. He didn't know they were there at that point. So in September of 2017, he was transferred from an acute tertiary hospital to a peri-urban hospital for wound healing. There was no specialist review for that. Our team wasn't informed that, because they're our lifelong patients, and nobody on our team knew. November, he was transferred to our unit when we were at Hampstead for rehab, supposed to be for seating, equipment and some reconditioning, because he'd been in hospital since July, so that's quite a while to be resting in bed. And we were told, yep, he's good to come. On admission, he had over 10 wounds. The majority of them were necrotic. Because he was in peri-urban, it was difficult for us to be able to go and actually see him. We had no reason to doubt that he was good to come. He had lost a huge amount of weight. He didn't have any appetite. We had a peg tube inserted as soon as we could after he came to us. He had osteomyelitis and was on IV antibiotics. Extremely severe diarrhea, which was making it worse. He came with a urinary tract infection. Each of those wounds needed to have an individual treatment plan. We couldn't do the same thing with all of them. Maintenance care just refers to something we have in our rehab setting where when somebody isn't actively rehabbing anymore, they get changed over to maintenance care. So it stops their rehab episode, which helps with data. It's all a bit complicated, but he couldn't perform any rehab at all, so he wasn't an actual rehab patient. We had a plastics team that would come out for a wound clinic once a month, and we asked them to come and have a look at this gentleman while he was on our ward. So we're now up to March of 2018. He went to the acute hospital and had his left hip debrided and came back to us. We're now up to July 2018, and we had something that were called wound beds. So we had, I think it was 4 or 6 beds that were specifically for wound care because people were being sent again to peri-urban hospitals. They weren't getting the care they needed. They couldn't be managed at home, but they didn't need to be in an acute hospital. At that stage, his right trochanter was unstageable. He had left inner ischium unstageable, left outer ischium unstageable, left lower leg unstageable, and that one was quite vascular, so we had to get vascular input with that one. His left heel was unstageable. 3 of his right toes were unstageable. His right knee was a stage 2. And September of 2018, he went back to the acute setting again. He did have a left above knee amputation for that vascular one because that leg was going to kill him. It was really bad. And that healed up fantastically, the wound from that. There were no breakdowns, no problems at all. It was beautiful healing. And then he came back to us. In October, these specially funded wound beds were closed, and we all kicked up a bit of a stink and said, no, Chester is staying on one. We're not sending him anywhere else. This happened to him in our health setting and he's staying. And there were several of us who said we would chain ourselves to the bed if they tried to discharge him. And we would have. We weren't going to let him go anywhere. November of 2018, he's now been in hospital for over a year. We escalated a request for some surgical management. They did some debridement and there was infected bone on view in the base of the wound. The surgical team at that time said that they weren't prepared to do anything else. They advised for him to just get up and sit and go home. He couldn't sit. The pain was so great that he could not sit. And this is someone who couldn't feel when he developed pressure injuries, but he could surely feel these. And it's because there was bone involved. So just for dressing changes, he was having OxyContin and subcut fentanyl just to do a dressing change. He couldn't move in the bed without pain. He couldn't sit. He refused to go to a nursing home. He said he would rather just go home and die. And we really advocated for him. At that point, the nurses would do his dressings and they would come out in tears because it was so upsetting. And this is just some of the pictures of some of his wounds. That one where you can see the little white bits in the middle, they're little flecks of bone. That's what the bone was like underneath. Another one there. Again, bits of bony bits on view. So they told this gentleman with skin like this to just sit and go home. So we did a lot of work with him. We actually had senior staff come and speak to him, explain the risks if he had any more surgical debridement. that there was a high risk that he could die because it was quite major surgery. He was fully aware of that. He did want the surgery because his only other option was to go home, lay in bed and die. So April 2019, he went to hospital and he had debridement and a flap. The plan was for him to come back to us when his wounds were stable enough. He was reviewed by our medical team every week. He did have complications. He had wound breakdown. He developed infections in the wounds. He had a urinary tract infection, respiratory infection. And then on August the 3rd, Chester died. He had spent 2 years, 1 month, 2 Christmases, 2 birthdays in hospital, and he never got to return home. So that just shows what can happen just from a pressure injury, from not looking after someone. And I know too, you put in everything you can and someone will still develop a pressure injury. But when it's not managed properly, this is what will then happen. So it was really upsetting when he passed, but Chester lived a life with a spinal cord injury to be proud of. And he taught us a lot about patience and resilience, about advocating for other people, the gentleness of him. He was brave, he was stubborn, he would grin and bear it. So there was one time when we had the wound people on the ward looking at him and trying to debride things. And we could see looking at him the pain he was in, and they're just, oh, he can't feel it, but he could. So making them stop what they were doing, asking them to stop. And he also had a lot of humour. He said he wouldn't have a haircut until he went home. So by the time he passed, he had that very long old man white hair and beard. So he refused to get that cut. And that's got nothing to do with it. It's just a little bit of lightness at the end of that. So laughing so hard that you snort and then you fart, then you laugh again because you farted when you snorted because you laughed. So that's Chester's story. And I know Paris has seen that before, and any of my staff that look at it, some of them will have seen it before as well. Just close this down. And we're back again.
Thank you, Helen,
Thank you.
for this presentation. And what a terrible story at the end.
Yeah.
And I think this is what we need to understand, how severe and important, how severely it can get, and how important it is that we do something in time. Because staying in bed, not being able to get out, that's, even though you survive, that will still be something that will be very hard to psychologically cope with. So
it's not a life, is it? It's not quality of life. And I think with him, that could have been stopped from getting so bad very early on with just having the right people. And at that point, there was a lot of moving people to peri-urban or country hospitals that didn't have the skills, and there's no way on earth that we'd blame any of those people. They did the best they could, but it's that specialised knowledge that we have of our patient groups, knowing how to fix the incontinence. And
and also, and I think that's something that we struggle with in Denmark, is that we know a lot about people with spinal cord injury, but lots of people from all over the other wards, they don't know. So the red mark, they won't see any red flags or alerts, and they say, well, this will just heal in time and no problem. And then it gets too bad before we even get involved in managing the wounds. Yeah.
It's a bit
and
like
also,
that. Go on.
Well, I think it's both in hospital, but it's also when the people get home, if they are unable to look at their skin themselves, and they need staff to do this. If the staff doesn't know, new people and somebody without enough education to know how important this is, then things will just get very bad. And then they need to contact the specialists and
the right people.
Yeah. So what we try to say to the spinal cord injured persons that we get in contact with is that make sure that you make the connection to somebody who knows something about this.
Yep. We have, I know, in New South Wales with Ruth, they have quite good outreach services. We have just a very small service that everyone working on there is part-time, so the nurse on there is only 2 days a week. But it's something to keep contact with people in that first, I think it's now 12 months, the first 12 months after they leave hospital, they have that closer contact and stay in touch, and will feedback to us if there's something extra that they need that we can help with. And then they kind of evolve into having our paraquad, which is our paraplegic quadriplegic association. They will take over a lot of that afterwards. But we do keep seeing our patients, so they'll come back for medical reviews, and they cover everything. So they go through everything in those reviews, and then if there's any particular problems, if it's continence stuff or skin stuff, they'll get in touch with us on the ward as well.
We most of our quads are probably 15 years post-injury, so they're set in their ways, don't get renal stuff done, you know, they just do the same things year in, year out. So we've got a couple at the moment that have pressure injuries, and because they are on an NDIS plan, which is an insurance scheme thing here in Australia, Randy, community nurses from the public hospital won't go to them because they've got finances through this scheme. So they have to look around and get a private nurse or organisation to come and assess the wound. I mean, we can do ours, but quite often what we've found is because we just do a lot of catheter care and that sort of thing, we don't have a lot of consumables for wounds. And, you know, just wondering what's the first line or first thing to do. I know you assess it and see what type of wound it is, and but mostly people just have a bit of betadine and some non-gauze in their house. So we kind of just, you know, give it a wash and betadine and cover it. Yeah. Yeah.
And there's not much more you can do. People can't have a supply of wound care just in case something happens. They'll expire if nothing else. But it's trying to find where they go to next, because there is, with our NDIS, there is a lot of new services that have popped up. I don't know what kind of skills they've got, what kind of experience with people with spinal cord injury. But when they're leaving our service and going home and they've got their NDIS funding, I can't refer them anywhere or set anything up because I can't manage their funds. They're either doing it themselves, or most of ours will have, you know, someone managing it for them. So they're the ones that have to set it up, and we just don't get any involvement in that.
Yeah. And I've got this guy at the moment, he's probably 39 years post-injury, but he suddenly got a scrotal injury. And so what he's done, he's quite an alternative guy, and you may have heard of it before, Helen, but he, with his Roho cushion on his chair, he's got someone to tie the cells together with the rubber band so that there's a hole where when he's sitting, his nether regions sit in there. And I think it might be working because it hasn't deteriorated, and he wants to get up. He doesn't want to stay in bed. Yeah. Have you heard of that? The tying
yes, tying them off, which they've then just got to be careful, because you're closing 2 cells down, or however many, that the other cells are going to increase pressure. So they just need to be, it's not something I would recommend to people to do, but we know people will do what they can. Yeah.
Yeah. Yeah. And he was even trying to look around for a Roho donut. I said, I've never heard of it,
No,
but
no, neither have I.
would create other problems or other pressure, I would think. Pressure.
Yeah,
Yeah.
I wouldn't use a donut for anything
Yeah.
except eating.
What was that?
Except eating a donut.
Postpartum. Yeah. Got any
I have a
questions,
question.
Elliot?
Well, I have a question for you, Helen. You said the paper test for the heel. Can you
Yep.
explain what that paper test is?
So can't really show it here. If that's, oh God, my arms don't even want to bend that. If that's someone's heel, you should be able to put a piece of paper there and just slide it out. It shouldn't be trying to pull it. That means I always use my hand and cup underneath and make sure that heel's not touching anything. But if you can at least slide a piece of paper in, it means that they haven't got any pressure going through. And some of the foam mattresses now are coming with oh, look, it's like pressure relief for dummies, where the end of the mattress slopes down a little bit more, so you'll have the foot hang, so there's no pressure. You don't even have to think about it. So they're a nice foam mattress.
But I think this is also something that is, well, in our countries, we will have access both to wound dressing and to other types of equipment to release the pressure and shear and things like that. But there may be some countries where you don't have access even to mattresses that are good. So so then you really need to be creative.
Make do. Yep.
Yeah.
Be creative. We still have a problem in Australia where people over 65 really get nothing. It's all just through my aged care. Trying to get wound care for them is near impossible. So that's not great. Continence stuff for them is impossible. Because, I don't know, the government seems to think when you're 65, you should just be put out in a paddock and die.
Yeah. I've got a picture. I don't know if you can see it.
Oh, is that what's left of toes?
Yeah.
Wow.
Yeah. And he's just come out of hospital. That's his other foot.
Yep.
He's had some of them cut off.
Yep.
So to me, I took that from the inside or the inner, but it just, to me, it looks like it should be debrided. Do you think that? It's not
It's a bit hard to tell on that one. It's kind of shiny.
Oh, the other one was better.
Yeah, the other ones were better. That one's a bit hard to see.
Yeah. Oh.
Yeah, there it is.
Yeah. He's a para.
Yeah.
And he's on his tummy because he's got a sacral pressure injury. Yeah. I'll see.
And is that how he got the toe ones, from being on his tummy?
No, he's had them for years.
Okay.
I think, yeah, he just doesn't manage himself very well.
Yep.
And not compliant really, but he just wants to be at home.
Yeah.
Yeah. So he just wants us to put like a betadine gauze in between the toes and pad it up. Basically, crepe bandage. Well,
that'll help stop a bit of infection, I guess. It's not going to hugely help it to heal.
Yeah.
Unless you got one of the, like an iodazole paste or something, which might help with getting rid of some of the crusty, fluffy bits, and also it's got that, I don't know if it's iodine, betadine, something in there as well, so that he might be okay with.
Yeah. Yeah. Get him to buy some stuff.
Yeah.
Yeah. For that.
Ruth or Annette, have you got any questions about the course or the finishing of it, or any problems that you might still be having?
I don't know if Annette can get off mute, but can you get
Maybe
off
'cause
mute, Annette?
No, I thought I might be able to do it, but it won't let me.
Hey,
There she is.
She's here.
Yeah. Oh,
Any questions, Annette?
no, but just everything just seems to be harder for quads. It just should that's what just hit me listening to you. Like, you know, trying to get dressings for them and all, like it's just atrocious. That's what I'm. The care with carers, as well as care providers, as well as the hospitals that don't know what to do with it. It's just terrible.
Yeah.
I don't, you know, it's, you know, and they're worse off with the NDIS. There's no two ways around it. Even with carers.
It's variable. We get some people who they get fantastic plans, and others you've got to argue about everything.
Yeah,
It's like it's their own personal money, particularly things like, you know, hydrophilic catheters. They've started pushing back a bit. They seem to have stopped that again now, but you know, you tell them all the reasons, and you know, sometimes I just want to get some of these people and give them a dry Nelaton catheter and say, go stick this in your urethra, dry, for the next 6 months, and then tell me what you think.
It's insult that someone without experience is actually assessing them.
Yeah.
Like that to me is just an insult. It's ridiculous.
I was in a planning meeting the other day, and I tend to not go to most of them, but this one was a little bit complicated and wanted to support the patient a bit more. I was in there, and the planner, I'd already sent through all the documents and then asked if this patient had had a continence nurse assessment. And I just went blank and didn't know what to say. And thankfully the OT said, well, that's what Helen does. That's the role for a spinal nurse. But I just went blank. It was, what do you think we do? And honestly, a general continence nurse has no idea. Well, I shouldn't say across the board. A lot of them have no idea on managing a neurogenic bladder or a neurogenic bowel. They don't get all the nuances of that. So that's what spinal nurses do.
When that guy went to hospital in the country, there should have been some sort of alert or something, or some sort of mandatory.
Yeah.
They've got to, you know, like let.
Yeah, they don't have. Oh, these automatic lights are very annoying. I can never turn them off when I want them off, and then they go off. They just didn't have the skill set there to manage with it.
Yeah.
But we were most annoyed that they said he was ready to come. But again, that's probably not understanding what rehab is and what we do and what's required. So it was a bit of a lesson for us to check things a bit more now and to get photos sent to us if we can't get there. So we learned a bit from that too.
Yeah. And would they automatically put them on a air mattress normally, like spinal, wherever they go?
I think that happens a bit more now than what it used to happen. Even in ED, they're getting air mattresses for barouches and things. So that's getting better across the board, but it's still not as good as it could be. The other thing that's not good is bowel care. So someone goes into just a general ward for something and they won't do bowel care. But unless they can do it themselves or they'll let the carer come in, they don't get bowel care, which is really bad.
Why?
Because it's that old thing of, you know, you want me to stick my finger where? Or I'm not doing that. I'll perforate the bowel, or why?
But this is in a hospital.
Yeah. So someone will go into a medical ward for something, and we know they're going to come back constipated and probably with a UTI because they don't understand it. And it's not their fault. They don't understand, and they would rarely get someone with a spinal cord injury. But we're here and we can be asked. And in our acute hospital, where we've got our acute spinal cord unit, the other wards have got somebody right there that they can go and ask, but it doesn't always happen.
It's terrible.
But something must be better, because we, 10, 15 years ago, we'd get the people who were coming in all the time with the pressure injuries, the repeat ones. We don't get that as much now. So there must be something better out there with the care and the management, because a lot of those ones have now passed on. They were older, and we don't see them the way that we used to. And that could be equipment is better. Seating and cushioning is so much better. Or they're out there somewhere and we just don't know about it.
They don't want to go to hospital, do they?
No.
No.
Even from here, from rehab, they don't want to go to hospital for anything.
Yeah.
Yep. Well, we can't intubate you and put you on a ventilator here. If you get to that point, will you go to hospital? Well, yeah, I suppose so.
Yeah.
Well, this was our last Zoom.
It was fantastic.
Thank you.
Except for trying to log on and do all that.
Oh, you had trouble?
Oh, yeah, well, yeah, Bruce had to help. I couldn't do it. Yeah.
We will send this one out as well. We just need to figure out if it's going to be by letter or on Facebook. But
I wonder,
we'll
we should be able to get them to MailChimp it out, do an extra mail out with it, which will be easier than us trying to send multiple emails for 1,200 people. And I'll put it on Facebook as well. So usually Paris will send me through the recording of it the following day, and then I get it uploaded that way.
So
And the others,
a couple of days.
Yeah, and the others are still there. I'll leave them there for a couple of weeks and then I'll take them down. I don't think they can be downloaded or copied. I hope not, because I don't want them to be.
What's this? The course?
The Zoom meetings where we've recorded them.
Oh, okay,
and putting them on YouTube. So they'll be up there for a few more weeks. The eLearn SCI site is always available. So anyone can go in and just, do whichever modules you want to. We'll probably run this.
There are some modules that we didn't cover in this MOOC, so that's worth taking a view. And you can look in the nursing modules, but you can also take a look in the other health professionals,
the doctors,
modules.
the consumer ones. And we'll probably do this again early next year. once we get all our feedback and see if 1,200 people did actually do it or start it, and we'd look at the other topics that we haven't done. So we'll do them that way. But it's certainly been a learning curve for me.
Me too.
Yes, I now know how to share screens and Well, that's our hour up. So I'll say good night.
Yeah, thanks a lot.
Take care. Thank you for participating.
Have a lovely time at Cena next week. Are you going, Annette?
Yeah, aren't you?
No, I can't this year.
Why?
No, I'm very disappointed, but I've got a medical thing on the Friday that I can't change, so I will miss it. I have said, though, I'm more than happy to have it next year. I'd love to have it back here next year. That's just our smaller Australian Spinal Injury Nurses Association, Randy, and we do a conference each year.
I'm sorry you won't be there. I was looking forward to seeing you.
Yeah, so am I, but it's not worth coming over just for the one day. It's expensive. You want to pay my flight?
Expensive.
I am still hoping I will get over to Sydney sometime in the next few months, because I also means I can't catch up with my son and his lovely girlfriend that I haven't met yet. So when I get over there, we'll do a catch up and
I like that.
Yeah.
Thanks a lot.
We'll invite you too, Randy, but it's a long way.
Thank you very much.
All
Thank you very much for everything. Yeah.
Okay.
Good night.
Bye.
All right.
Be in touch, Helen.
You can mute me now.